Okay, so I would now like to welcome Dr. Fatta Nahab. He's a neurologist and vice president of the company Neuron 23. Their focus is on developing personalized medicine for neurodegenerative and immune conditions, with their initial program pertaining to LRRK2 interventions in Parkinson's. So yeah, welcome Fatta, and take it away.
Thanks very much. Good afternoon, everybody. It's good to be with you. Thank you for the organizers including us in this discussion. I think the presentation is going to piggyback very nicely on Dr. Henry's presentation and look forward to your questions.
Yes,
great. So you're all experts on LRRK2 now. And so we can probably skip ahead a little bit to some of the more basic slides, but there we go. Just an initial disclaimer. So maybe just a little bit about my background. I'm a movement disorder neurologist. Spent about the first 20 years of my career taking care of patients, many of them with Parkinson's, worked in an academic research environment, that sort of thing, and then moved to industry about 6 or 7 years ago now, and I've been with Neuron 23 for a couple of years. So this presentation is going to tell you a little bit about a clinical trial that's currently ongoing. This is not a medication that is FDA approved. It's currently in trials, and so take that into consideration based on what we're going to talk about. This is the amount of knowledge that I thought you all already had under your belt. But the bottom line is, there is no single cause of Parkinson's, and so we're unlikely to ever get a single targeted cure that's going to help everybody in the same way. That may seem obvious, but 20 to 25 years ago in the field, everybody thought that if we could simply fix the dopamine problem, everybody would be cured, and that hasn't been the case. And the more time that goes on, the more complicated this picture gets, and the more variety we see in terms of the causes and the underlying mechanisms of Parkinson's. All of the treatments that are currently available really address the symptoms. I used to tell my patients there's 31 flavors of dopamine, just like Baskin-Robbins. And so bottom line is, that tends to be the most common way to treat symptoms, but it doesn't actually slow the progression of the disease or actually do anything to the underlying causes of Parkinson's. And so the goal for all of us, you and us and researchers, is to figure out, is there a way that we can slow Parkinson's? We don't even want to think ahead to a cure, because before we run, we've got to first walk and understand what could be potential causes and how could we slow those things down to give people more positive, productive years where the Parkinson's doesn't actually slow down their ability to carry out their activities and enjoy life. And so, we'll talk about cure in the future if we can figure out how to slow this down in the near term. Dr. Henry did a great job of telling you about LRRK2. We know that, like she said, in certain populations, the people with LRRK2 mutations across the world, maybe it's about 1% to 2%. If you look at people in Israel or people in North African Berber populations, it can be 10, 20, even 30% of people. But as a whole, most individuals with Parkinson's don't have those rare LRRK2 mutations. And so those mutations we're talking about are, you can't really see this, the rare variants that you can see on the top right figure. They're relatively rare, but we know they cause a significant increased risk of giving you Parkinson's. What we know a lot less about are what are called common variants. And common variants are basically things that are slightly different than what the population has. They don't necessarily guarantee you get Parkinson's, but they appear to increase your risk for developing Parkinson's. And having one common variant is probably not enough. Maybe it's 2, maybe it's 10. We don't know at this stage. But the strategy that our company is undertaking, and I'll tell you a little bit more about the next few slides, is LRRK2 potentially relevant beyond those 1 to 2% of individuals that are known to have a family history, that are known to have a rare variant mutation? And so we've taken a slightly different approach in terms of trying to understand this population. The other point I will make is at the very bottom, which is I'm going to tell you about a genetic test that we are running that we have developed. But oftentimes we hear back from people, well, I've already had my genetics tested, and I don't have LRRK2. So why am I doing this again? And I want to emphasize that the genetic tests that are currently done, whether clinically or for research purposes, such as through PD generation, are basically testing whether you have one of those rare variants, but they're not testing whether there may be some of the more common variants that we are working to identify. Dr. Henry also did a great job here. Bottom line is the LRRK2 protein, when it's overactive, appears to increase your risk for developing Parkinson's disease. That figure on the right side shows you 4 different, or at least 4 different rare variant mutations. And depending on how overactive that mutation is, determines your likelihood of getting Parkinson's. And so the one at the very top right, that Y1699C, is about 10 times more active than somebody without a LRRK2 mutation. And those people are nearly 100% likely to get Parkinson's. Compare that to the people at the bottom left. Those are slightly more elevated than normal, and there's only a slight increased risk. And that's just the rare variants. We haven't even talked about the common variants that I want to tell you a little bit more about. So the approach that we've taken is to ask the question, is it possible that people beyond just those with rare variant mutations may also have elevations in LRRK2? And how do we identify those individuals? And why would we want to identify those individuals, you may be asking yourself. But you've already heard that there are companies out there that are developing LRRK2 inhibitors to see if they're slowing down Parkinson's disease. Well, I would guess, we don't know yet, and we're very enthusiastically interested in learning what the results are of the Biogen Denali study, because if that looks like it works, it's going to be wonderful news for everybody, because it would suggest inhibiting LRRK2 can benefit everybody with Parkinson's. And that's fantastic news. And that's really an exciting development for the field. The other possibility is that a LRRK2 inhibitor may only help individuals with elevations in LRRK2. And so that's really what we're trying to focus on, is could we identify individuals in some way that have that overactivity of LRRK2 and only test LRRK2 inhibitors in those individuals. And so I'm going to tell you how we're doing that. So, you hear a lot about machine learning and ChatGPT and that sort of thing these days. We took an approach using machine learning to say, we know what individuals with LRRK2 look like. We know what they look like clinically. We know what they look like in terms of their age and ethnicities. We know what they look like in terms of their biomarkers profiles. And we know what they look like in terms of their genetics. Could we feed that information to machine learning? And could the machine learning algorithm identify people that don't have those rare variants that also look like people with LRRK2? And that's exactly what we've done. And so essentially, I'm sorry, the laser doesn't work, but the group of individuals here on the bottom left are what we call normal. These are individuals that have no LRRK2 mutations and that have no biology that suggests it's associated with LRRK2. The top right are those rare variants, and we know they have overactivity of LRRK2, and we know what their genetics is. The group in the middle is the group that we've identified that has a genetic profile that has no rare variants, but they look biologically like they have overactivity of the LRRK2 pathway. And so together, the LRRK2 predicted is what we call them, and the rare variants, we're basically saying have a LRRK2 driven Parkinson's. And those individuals with a LRRK2 driven Parkinson's are going to be the individuals that we're going to enroll in this trial of a LRRK2 inhibitor to see if we can slow down the progression of Parkinson's disease. The other point I'll mention to you is that group in the middle, you don't need to have a family history of Parkinson's to be LRRK2 positive. Whereas in the rare variant mutations, that tends to be more common. And so when people say, well, look, I don't have a family history and I've gotten tested and I'm LRRK negative, why would I get tested here? The large number of individuals in that middle group don't have either of the two, and yet they still look like they have an overactive LRRK2 pathway nonetheless. Now, we took the results, this genetic profile that we identified, and we looked across a lot of different genetic databases, which are listed on the right side of the page, to try to understand what percentage of people with Parkinson's may have a overactivity of their LRRK2 pathway. And what you can see is the range goes anywhere from about 33% of everybody with Parkinson's down to about 23% of everybody with Parkinson's, depending on the particular database. And so when we average across all those databases, our data suggests that about 30% of all people with Parkinson's disease have a LRRK2 based mechanism. Now, that makes it a lot more interesting if we're talking about more than 1 to 2% of people, talking about going beyond those with a family history of Parkinson's disease. And so ultimately, that's what we're going to be testing in this NEULARK trial that I want to tell you more about. So this genetic profiling that I told you about is being developed as what's called a companion diagnostic. And so there's a few ways you could get tested for this. I'll tell you about how we do it in the trial, but you can either provide a saliva sample to get this testing done, or within the trial, there's a blood-based test, which is kind of the definitive way that we can confirm whether somebody has LRRK2-driven Parkinson's disease. And so together, the rare variants, which tend to be more inherited, and that 30% of everybody with Parkinson's disease is really the population with LRRK2-driven Parkinson's that we're going to enroll in the NEULARK trial. Now, let me tell you a little bit about our LRRK2 inhibitor. Bottom line is a LRRK2 inhibitor is a LRRK2 inhibitor until you find anything different. And so to a certain degree, this targets LRRK2. We can demonstrate that it reduces LRRK2 overactivity. Dr. Henry is spot on in terms of targeting at least an 80% reduction because we don't want to knock it down to 100%. And what you see on the right is our ability. The black bar on the left is before baseline LRRK2 activity with a placebo. And then when we looked at different dosages, 5 milligrams, 15 milligrams, and 30 milligrams, with our drug, we were able to show a dose response where the higher the dose, the more we were able to inhibit LRRK2. And we did that in healthy adults and healthy elderly individuals as well, just because we know that sometimes when somebody is older, they may be a little bit more sensitive and we don't want to overdose them. And we show that similar doses are going to be effective in both adults and older individuals as well. So the dose that we selected is 30 milligrams. And so going back to the question of how do we figure out whether somebody is LRRK2 driven or not? If we put that burden on clinical trial sites, if only 30% are positive, there are going to be a lot of disappointed people out there because 70% of people are going to spend their time going to see if they're eligible for a trial and are not going to be eligible. And so what we've done is we've developed a genetic pre-screening study, which allows people to go directly to a website, answer a few simple questions. And the simple questions I can tell you already: do you have Parkinson's? Confirm your age, because we're looking at a particular age range. And are you currently on any Parkinson's treatments? Because we're only enrolling individuals that are only on MAO inhibitors, and I can tell you what those are if you want to know. But we're not enrolling people on dopamine medications because we want to catch them as early as possible. And you'll get a saliva sample. You'll provide your sample and mail it back, and in about 2 to 3 weeks, you'll have the results by email telling you whether you're LRRK2 driven or not. That's it. And if you are LRRK2 driven, then you are eligible to be referred to a clinical trial site that's near where you live. And if you don't live near a clinical trial site, we'll even provide the transportation for you to go to a more convenient location as well. But essentially, this is what we're doing to try to figure out who's LRRK driven and who's not. And only those individuals would then be eligible to participate in the NEULARK trial. This is a listing of the inclusion and exclusion criteria for the study. Age range is 40 to 80. Got to have a diagnosis of Parkinson's. You got to have that positive companion diagnostic test for LRRK2 driven Parkinson's. You're unlikely to be, you're not on medications and you're unlikely to need them for a year, but that doesn't mean you couldn't take them for a year. So we can talk about that if you have questions about that. And then it talks a little bit about your severity of Parkinson's. Basically, we don't want people that are falling or are using wheelchairs and canes because we need those individuals to be able to walk using the technologies to measure their progression. And you need to be in a fairly cognitively normal state. And we're excluding people with other causes of Parkinson's, uncontrolled diabetes, and significant medical conditions that may make a participation in the study not the best use of your time. And so here's an overview of the study. It's currently in the US. We're about to get going in the UK, and then we're moving to the EU thereafter in the next few months, as well as Israel. And 50% of people will randomly be assigned to drug and 50% to placebo. That for most people is a deal breaker right there, but I will tell you that there's also what's called an open label extension, which means that everybody who completes the study at the end, whether they got drug or placebo, will be eligible to get drug for an additional period of time, because it's really not fair to force somebody to get a placebo and then say, well, see you later, thanks very much. And so in this case, everybody gets drug at the end of the study if they so choose. And we're looking to enroll about 150 individuals across all of these sites and countries. And there's a little bit of additional innovation in the study. Most of you probably go see your doctors, and when they measure your symptoms, they want you to tap as quickly as you can. And somehow that magically tells everybody how you're doing and how your Parkinson's is progressing. And the way you look in clinic could be very different from the way you are at home. And so one of the things that we recognize is it's probably more important to check how you're doing more frequently, but for shorter periods of time. And so in this particular study, you're going to get a smartphone and you're going to get a smartwatch that you'll have to wear rarely. With the smartphone, every day you'll do activities on your smartphone that mimic some of the activities that you can do in clinic, but only takes about 5 to 7 minutes to do on a daily basis. But when you do these things on a daily basis, we have a much better idea of how you're doing at baseline and how you're progressing over time than simply looking at you once a month and making assumptions about, was this a good day, or was this because the drug is working, or was this the drug not actually helping or having other side effects. And so this is a way that we can track your symptoms much more regularly over time while minimizing how much burden it takes to go to your clinical trial sites, to spend hours upon hours at the site getting multiple evaluations. And so this reduces the burden while giving us a much better idea of how you're doing over time. And that's basically it, this QR code. If you are interested, you can open your camera app on your phone, and a link will pop up that takes you to the NEULARK website. And from there, you can actually learn to see if you want to get tested for LRRK2 driven Parkinson's disease and learn whether you're eligible. I think from my point of view, I would say whether or not you're interested in participating may be interesting to get tested. I think the point was made earlier by Helen, which is, in even 5 to 10 years ago, patients would come in and say, should I get genetically tested for Parkinson's? And my response was, well, there's not a whole lot we can do. So sure, it'll aid science, but it's not entirely clear how it'll help you. But I think we're at an era in Parkinson's disease where there are so many treatments that are related to your genetics and not just that 1% or 2% anymore, to where knowledge is not only power for you, but it really helps the field to advance. And I will say that ours is not a test for clinical purposes. That should be done by your clinician through a clinical certified lab. PD generation is a great resource. We actually use PD generation as well to identify individuals that may have LRRK2 driven Parkinson's as well. And so I'm not saying do this instead of everything else. It should be in addition to everything else. But I think these are exciting times for us, and we'll see where things go. And happy to take any questions. Yes.
Well, I happen to have the LRRK2 G2019 assay, and I also have a very strong family history. And I don't have Parkinson's, so I don't qualify for your study. But it is interesting about the investigational genetic variants that you're looking at. And I was just curious because, of course, even with the LRRK2 G2019S is not fully penetrant. And so I was just curious, have you looked at those genetic variants and like the non-manifesting carriers and manifesting carriers to know if it's like modifying risk or in addition to, or
Yeah, no, I think that's a really interesting question, which is, let's say you have LRRK2 overactivity. One, are you guaranteed to get Parkinson's? And I think we know the answer is no. But in these individuals that are in the middle, that may have slight elevations, what is their risk profile? And if we go back to people that are pre-symptomatic, like yourself, maybe you never go on to develop anything, or maybe it happens in 5, 10, 20 years or something of that nature. And could we follow those individuals into the future and to say, hey, we predicted this overactivity of LRRK2, and sure enough, 15 years later, this manifested. And so when I said earlier on, we need to walk before we run, the reality is if LRRK2 inhibition shows efficacy in individuals with Parkinson's, it'll probably also show efficacy in delaying or maybe preventing the onset of those individuals that are at future risk for developing it. But until we know the here and now, we really can't go into the future because those studies are long. They need lots of individuals. They're very costly. And I think while the data is partly being collected, the amount of in-depth data that you need is enormous. And so I don't know of any data sets currently available that have been collecting for 20 years that we can go in and to say, look, these are all the people that now have it. Let's go back to their genetic profile, because genetic technology has really advanced over the last few years as well. So that's the future, assuming we can move things along. Yes.
So just to piggyback on that, the Parkinson's Foundation is starting a pilot that's following families. It's going to be called PD Gene Families. So to just start that, but no, I don't need to talk more about it, but just so you know that it's coming, it's coming.
We work together.
Yeah, we do. Yeah. So there's a sub-study coming out of the foundation that's going to invite the family member that participated in PD generation. Okay, great. And then he would be able to invite you to become part of the study. And then we could collect different information and work with our researchers to start building that database. So we're really at the beginning of collecting that information, but it is coming. My other question is, for the LRRK2 inhibitors, do you think it would be possible to dose people depending on their profile? Like, would everyone get the same? I understand the trial, everyone's getting the same, but would you see into the future that you would tailor it even more specifically?
That's a question I asked. So the
That's myself.
yeah, so we're talking about needing to inhibit it, and we're talking about in some people it's 10 times overactive, and in some people it's 5 times overactive, and in some people it may be 2 times overactive. The problem is that activity level that we know right now, you can't actually identify in the living body. These are cells, these are DNA profiles, and so the current gap in the field that we have is I don't have a way of testing you and saying your LRRK2 activity is 5.5 times normal, and so I'm going to dial in this level of medication. Could that happen in the future? Absolutely. But I think the gap that we have right now, and we've got a LRRK2 conference next week where we're talking about these issues to try to figure out where the field needs to go next. A way to monitor the levels is exactly where we need to go, but we're not there yet. So fully agree. Yes.
So the study sounds like a year long, the trial. And that does that involve a monthly appointment? Does that involve blood draws but not spinal? Is that right?
I know exactly where you're going. Yes, so spinal fluid is optional. No scientist would ever pass up getting it if you offered it.
Yeah.
In terms of the study design itself, after you are found to be LRRK2 driven, there's a screening visit where you talk about the study, you see if you're eligible and whether you're interested. And then you'll do a variety of tests, both imaging and labs, just to make sure you're healthy, you have Parkinson's and the like. And then, because I told you we're using technologies, it's not intuitive that somebody just gets in and knows how to do these things. And so we've got a 1 month period where you get the technology and you're using it on a day-to-day basis to get comfortable with it and to improve your performance. Because sometimes simply doing something over and over again, you look like you're better and it has nothing to do with the drug itself. And then after that 30 days, then you get the drug, and they're typically monthly visits, which in the beginning, they may be slightly longer because we're doing blood draws to track the drug levels for the first week. After that, it's just usually a 1 blood draw per visit, and maybe 2 to 3 hours per study visit all the way through to the full year. And then at the end of the year, I mentioned whether you don't know, I don't know whether you're on drug or placebo, but then everybody is eligible to participate in that open label extension where you get additional drug for a 6-month period of time.
Yeah, I lost track of how many visits that was.
You remember offhand, it's more than 12. I think it's probably 14 or 15 visits, if I recall.
Like once a month, but a little more
at the beginning up front, there are more visits, but otherwise it's a monthly thing.
And you really cut back on your pool when you say no dopamine replacement, no Cinemet, no levodopa.
Everybody asks, why would you do that? So I'll tell you why. Because when I was exploring this role, I asked them the same question. So when you're not on dopamine medications, your symptoms are actually more severe. And whether it's the UPDRS that your clinicians do, whether it's these digital tests that you're going to be able to do, there's much more variability and room to detect a change. When somebody starts dopamine, their symptoms don't entirely go away, but they almost go away. And the ability to detect a difference on levodopa is very hard. And so for us, in our trial that I told you, we're only enrolling about 150 people. It's 150 people because we're using the digital technologies. It would otherwise be over 600. And if we enrolled people on dopamine, it would probably be over 1,500 people.
Sure.
That takes longer, that costs much more money, and it's still going to be difficult to identify things because it's so hard to find the difference between the group that's on drug and the people on placebo.
But you're throughout the monthly appointments, you're trying to track movement. You're you're sending in data,
Yes,
and that data is data about my tremor, for example, and
it's much more than that. So, you know,
my sleep, my cognitive. all
exactly,
that, Yeah.
exactly.
And so if you're on levodopa now,
Mhm.
would you take a subject who's willing to stop their levodopa?
No, because I think that's inhumane, number one. Number two is
It's their own choice.
number two is if you're on it, you probably needed it. And I would hate for you to start the trial, go 2 months, and then need to start it. Now we
Right.
put you at additional risk, and the data that we're going to be able to get out of this is also more limited. And so that's the challenge is I get emails from sites every week. You know, I have a patient who just started last week and they really want to participate in the trial. What do you think? It's up to the individual and it's up to the investigator. But I think from my point of view, you know, I didn't start people on levodopa willy-nilly. You know, if it was impacting their life, then they needed it, then they got it. And so more than likely, people that are on it probably are benefiting from it. And the last thing we want is somebody that goes off of it, falls, hurts themselves, some other complication from that point of view. So that's really the rationale.
Got it.
Yeah, good question. Yes, sir.
Can you explain what is an MAOI?
Yes. So there are medications that are dopamine or pretend to be dopamine, and there are medications that recycle dopamine. The MAOIs recycle dopamine, and they're things like Azilect or Rasagiline, Selagiline or Eldepril, and Safinamide. And so that's a category of medications that are very, very mild. Usually you'll give them to somebody at the early stages instead of not putting them on anything at all. And so if you're on one of those medications, that's okay because it's such a mild medication and it's not going to confound the results of the data that we're collecting. And so that's the one that's allowed. Yes, sir. Thank you all for your attention.